morning session. We would like to progress on to the afternoon session. The session is based on degenerative cervical spine pathologies. I would like to invite the chairpersons, Dr. S.N. Mathuriya, Dr. Deepak Gupta, and Dr. Manish Agrawal to grace the stage. The speakers for today would be Dr. Christopher Gerber, Dr. Hemant Bhartiya, Dr. Sushil Patkar, Dr. Atul Goel, Dr. Narasinga Rao, Dr. V. Rajashekhar, Dr. S.S. Kale, and Dr. Subodh Raju. Now I would like to hand over the mic to the chairpersons.
Good afternoon. So first, I would like to call upon Dr. Christopher Gerber, and he'll be sharing his experience on complication avoidance in subaxial cervical spine injury. He's a senior consultant neurosurgery at INK Hospital, Kolkata.
While we're waiting for the slides to start, I'd just like to say good afternoon. And I can see the audience today is full of eminence grise, people who, like me, have had many hard years of experience in surgery, battling with indications and complications of surgery. And I'd like to share with you today some of my experiences on how to deal with these things and what to do from there. The first case is actually, with a couple of cases, the first case is a recent case, a chap who underwent cervical laminectomy, routine operation for long segment cord compression due to OPLL. And the operation was uncomplicated. I don't have the pre-op MRI scans to show you. And everything was fine, 24 hours was fine, but the next day he gradually became completely paraplegic. So if you just bear this in mind, later on we'll come back to the case. And I just want to now talk about how we're going to avoid complications. Again, a little story. When I first started doing neurosurgery back in the mid-80s, we did all sorts of operations, anterior, posterior. I've done Clowards, I've done Smith-Robinsons, I've done total disc replacements, laminectomy, everything has been done. So I have probably seen most, if not all, of the complications that are possible. But I'm sure, even at my age, there's still more I can see. And the topic of this talk is the fact you should never let your guard down, and you should always expect some new complication to occur, so you should know how to deal with them. So firstly, I want to talk about two main topics. First is the neurological complications, are probably the most devastating, and less commonly some vascular complications. And as this on the side shows, basically a complication that happens to a patient is because of you. Okay, whether it's, we'll talk about pre, post, perioperatively, it's your complication. You have to learn to deal with it, and you have to get yourself out of it as well. So first of all, on the definition, what is a complication? A complication is an extra problem that makes it more difficult to treat an existing illness. It may be caused by the disease, the treatment, the procedure, that is to say the surgeon, or may be completely unrelated. And when you're consenting patients, how often do you quote all the complications? If you look at the figures here, this is a recent paper in Nature which showed that more than a quarter of all patients who had spine surgery developed a complication. do you consent all your patients before surgery, say, one in 4 of you are going to have some sort of complication from the operation? The answer, I would guess, is no. And the complications range from, if you look here, sorry, just go back. The CSF leakage, vertebral artery injury, which I'll talk about in a second. Premature termination means something that actually happened during the operation, which stopped you completing the operation. Nerve root damage, or in my case, I talk about spinal cord damage, and cement leakage. And the complication can be anything, either surgical, 30 days, or systemic, UTIs, cardiac arrest, respiratory tract infections, anything. They're all complications, and they all happen much more frequently than you think. So again, you look at this slide here, that again, this is another paper done a few years ago. Sorry, and it showed that the actual complications were very common. 44% of all patients with degenerative spinal disease had complications during the surgery. But if you're operating for tumor or any other infection, the complication rate was actually much higher. So again, let that figure sink in. 44% of all patients who had surgery had a complication. And what are the problems with that? I mean, again, you probably can't, I'll read it out for you. The complication rate was higher if it was prospectively recorded than if it was retrospectively recorded. So surgeons have a very good selective memory when it comes to complications. So all my patients do fine, there's no problems at all. But if you have a prospective report, then it's actually much higher than you actually think about it. An analogy of this is when I was training all those years ago, I was at a conference in Europe somewhere, and I was listening to this eminent professor talking about his results, and he said he had no complications. But sitting next to me was his junior, and his junior said, well, he does have complications. The only time he doesn't have complications is when he doesn't operate. So I think you have to bear all this sort of in mind. So when can they occur? They can occur anytime. They can, as soon as the patient walks through the door in the outpatients. If you have a bad rapport with the patient, the chance of there being a complication from the surgery is actually much higher. Peroperatively, we'll talk about post-operatively. They can be immediately delayed within a few hours, a few days, or after 30 days after that. And people have made money out of writing about the complications there and the things there. Another complication, and this has a huge medical legal impact. I mean, it's not some. I mean, you're quite fortunate in India at the moment. Is the burden of medical legal practice is actually much less than it is in a lot of the Western world. If I just quote to you, in England now, you can't actually get insurance from a company to do private spinal surgery because it's so expensive. They won't indemnify you. So what you have to do is you have to phone your own group and your own insurance company to actually deal with these complications. So a medical error, we talk about medical errors now. It's a failure of a planned action to be completed as intended or the use of a wrong plan to achieve an aim. It happens everywhere, okay? Most medical errors don't cause any problem to the patient, so they go unnoticed. That's fine, I was lucky, by the skin of my teeth. And as you get older, you can avoid more errors, but you're actually better getting out of situations than you are when you first started doing surgery. However, sometimes an error can cause a detrimental adverse effect, and that's defined, as you see here, as an unintended injury or complication caused by medical management resulting in measurable disability, prolonged hospital or stay or death. How do the errors occur? I mean, there's two basic models here, and I think the reason I'm talking about this now is because, again, places I've worked before, there's a lot of stress made on trying to avoid avoid complications, avoid errors, etc., etc. And you have the sort of what we call the Swiss cheese model. Has anybody here heard of the Swiss cheese model? Yeah, I mean it's very few, far between. And what it is, you have, if you look on this, if I just press here, Swiss cheese is basically holy cheese. It's as it named, it comes from Switzerland, especially. It's very tasty, I must say. But what you have here, this is what we call the blunt end, okay, and this is the sharp end of a patient's treatment. Sharp end is where damage can happen. And what happens is on the way to every patient's treatment, you have walls, safeguards like this. And the problem is these safeguards aren't impenetrable. They've got holes in them like Swiss cheese. So every step of the way, you can have an incident which will end up in some sort of medical error or some complication occurring in the patient. And the reason I'm saying this is the fact errors are usually the result of multiple factors. There's not one problem causing an error in a patient treatment. And again, the next slide goes about this, and basically it looks at, this is a very complicated slide, but it actually looks at errors are usually systemic, and there's not one factor which can cause it. We heard again this morning, again, this is completely coincidence. We heard about the Dunning-Kruger concept, and again, I'll talk about competence in a second. And we had the analogy this morning about surgical training or spinal training, whatever you want, neurosurgical training, is like riding a bicycle. And as you say, what happens is the different discussions of what that means. Basically, when you start riding a bicycle, you don't straight away go onto a free bike. You don't go on a full-frame bike. I do lots of bicycle riding, so I know all this thing. You start off with little extra wheels, support wheels, so you don't fall off. The support wheels may be your tutors, maybe your institution, maybe your mentors, blah, blah, as you go on. So that's fine. The problem is, as you get older, you get faster and faster, and then there's a stage, usually they say in your 40s, 50s, where you're the best you're going to be as a surgeon. Okay, after that, I'm afraid to say it's all downhill. I mean, people may disagree with me, but I think your most competent part is, when you're mid to late 40s, early 50s, and that's when you have your racing bike. Okay, you have your supercharged bike, you're whizzing around, you're doing the Tour de France, you're doing everything, you're beating everyone straight, and that's fantastic. Then what happens is you get older, you get to my sort of stage, you start slowing down a bit, and you start thinking, well, should I get an electric bike? I mean, I'll go the same speed, but I need all the equipment that I need. And I'm afraid to say I'm a bit of a dinosaur from that point of view. Again, this may cause outrage in the audience. I don't do endoscopic surgery. I don't use the O-arm, okay? I don't use anything, modern contraption, anything like that, because I think a basic understanding of the anatomy, the techniques, and they're not necessary. These strategies are an adjunct, they're a help to the operation. They don't do the operation for you. And I know I've come across people who've been trained where they have lots of O-arms. As soon as they finish at their institution, they go outside in the district hospital. There's no O-arm, they just have a C-arm. They don't know how to operate. So I think you've got to be very careful when you're using medical technology from that point of view. And if you're looking at this slide here, just go back, sorry. This is probably the most important slide here. This is where all trainees start, okay? They're unconsciously incompetent. And with training, they go up to becoming unconscious and competent, okay? And which is what the idea of training, it's what your seniors do, your colleagues do, you're learning all the time. But the most dangerous people are the surgeons who never get past this stage. The ones who think they're good at everything, okay, and they have no insight, they have no idea. And we've all come across those people in our practice. So just a warning about these sorts of people. So talk again quickly about neurological disease. I've got 2 minutes, I have to be very quick now, so I spent a long time on that. Recurrent laryngeal nerve palsy is probably the commonest neurological complication in spinal, certainly anterior cervical spinal injury. And it's due usually to I believe it's due to indirect pressure from the ET tube. There used to be a lot of talk about it's due to retraction. You go operate on the left side, less incidence of having recurrent laryngeal palsy, you operate on the right side, et cetera, et cetera. But as actually studies have shown, the rationale for doing a left-sided approach was because there wasn't a recurrent branch of the recurrent laryngeal nerve on the left side. But that was only evident in 1% of cases. So you choose your side according to your experience. Who here goes from the right side? Who here goes from the left side? Nobody. I think, are you all orthopedics? Neurosurgeons here, or orthopedic surgeons? Neurosurgeons. What I found is orthopods do it from the left side, and neurosurgeons tend to do it from the right side. But that's a very sweeping statement. But it doesn't make any difference, okay? The only time you have to be careful, and I'm sure people have told you this, is the fact if you're going in on another patient who's had previous ACDF, either you go in on the same side of surgery, or if you go on the other side, you have to get indirect laryngoscopy first of all. Because having bilateral recurrent laryngeal nerve palsy is an absolute disaster. And this is just what it looks like here. Next one is Horner syndrome. Oh, just to go back on the recurrent laryngeal palsy, most of them get better. Even though it's temporary, it's good, only sort of 3%, less than 1% of them are permanent. Horner's is another one. Again, no big deal, but cosmetically, it doesn't look very nice. The patients don't thank you afterwards. Again, they all look better, and the incidence ranges from about 3% to less than 1%. Who's had a Horner's post-op here? Patients? Nobody? I'll put my hand up. I've had it. So again, the recovery is good, and to stop it happening, you have to put your retractors underneath the longest coli muscle and don't retract out too laterally. Again, now we're talking about neurological complication. This is an American. I think just go through this quickly. What we should see here, sorry. Yeah, I don't have much time. So back to this case. This patient deteriorated following 24 hours after surgery. What do you think the diagnosis is? Most likely diagnosis? Anybody? Hematoma. Yeah. Could be anything else. Yeah. Yeah, you could, if you're going from behind, it could be cord swelling. So, basically it's mandatory, time's up. So, mandatory to do post-op MRI scan. This was his scan post-op the following day. And the one thing you can take away from this, okay, there's a big hematoma there. There's also a drain there. Okay, so post-op drains don't stop hematomas forming. Hematomas form, usually in my experience, because of bad closure, bad operative technique, or some bleeding diathesis. Again, controversial. I think I'll just skip on to, I don't think I have time for, time to go on quickly about this, or should we stop? Yeah, okay. Vertebral artery injury happens, okay? More commonly happens if you're going to do a posterior approach around the C1, C2 area, but it does happen anteriorly. And people always think it actually happens at the bottom of the operative field. But if you look at this MR scan here, the vertebral arteries are actually quite posterior. So it's going to more likely to happen as you're going laterally out towards the disc. Usually happens during drilling and instrumentation, particularly in the posterior cervical area. And occasionally, in about 1 or 2% of people, you have anomalous vertebral arteries. And the problem about this one is the fact that actually there's quite a 10% morbidity and mortality from it. And this was from a paper, I forget the name of the author, actually, it was an Indian paper, who showed this anomalous vertebral artery. And what I would, the take-home message from this slide is the fact that you should look at your pre-op MRI scans. Look at where all the vertebral arteries are, because occasionally you'll get caught out from that point of view. Very rarely, but occasionally. It's happened to me once when I was doing this oblique corpectomy approach, which I think has fallen by the wayside, where you go laterally the neck here, you go between the longest coli and then the transverse process. You drill out the bone there, but you have to mobilize the vertebral artery to get to it. So it happened to me once there. The patient was okay, and this is a protocol which we can talk about if necessary about what to do. I put this up as a warning. This is one of my last slides. There's a surgeon in America who they made a TV series about, HBO TV series, and he's known as Dr. Death. In the court, he's a neurosurgeon, fully board accredited, blah, 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 immaculate credentials. One operation he did when he was operating on a patient, anterior cervical discectomy, he cut the carotid, he cut the vertebral artery, he perforated the esophagus, and he excised part of the sternomastoid muscle thinking it was a tumor. And when he put the implant in, when they reoperated him, the implant was just floating in the breeze. So I think that, he's this sort of unconsciously incompetent person. He thought he could do everything. So basically, you can't avoid, if you're going to operate, you're going to have complications. You can't help it. You have to know the patient, but you learn from the complications. Okay? Every operation is a learning opportunity. And I'd just like to thank you for inviting me to Jodhpur. It's a beautiful city. I'm having a great time here. Thank you.
Thank you, Dr. Christopher. It reminds me of a very famous quote from Benjamin Carson, a famous neurosurgeon from US who was responsible for craniopagus separation. You don't have to be a brain surgeon to be a valuable person.
Yeah.
You become a valuable person because of the knowledge that you have. And having a knowledge does not mean that you will not fail. The more important thing is that you have to just keep trying. I mean, if all of us have problems in our surgical career, but then we need to learn from the complications, and we need to openly talk about it, and then discuss it out so that we become better surgeons and we give a message to our youngsters also. We have time for one question from the audience or comment.
Yeah, I would say, that's the take-home message. As I said, you learn, you're going to have complications. You have to learn from them. If you don't learn, you become a worse surgeon. And you have to be upfront about them.
Thank you so much for your time. I appreciate it. Next, I call upon Dr. Hemant Bhartiya. He'll be sharing his experience with 500 cases of anterior surgical approach for cervical spine lesions. Dr. Hemant Bhartiya is Director of Neurosurgery at Fortis Escorts Hospital, Jaipur.
Final. Good afternoon. Thank you, Team AIMS Jodhpur, for inviting me. I would be sharing my experience and journey of anterior surgical cervical approach, which was started here in Rajasthan in 1988. And this is experience of these two institutions where I worked, the Santokh Durlabji for 22 years, and now Fortis Hospital for last 13 years. So the advances which have taken place over years in the surgical management, diagnosis, and instrumentation, we'll see that. This was the first case which we operated. Can see at C5 there is erosion, and this was Pott's spine, which was fused with bony fusion after removing the granulation tissue. As we all know that the degenerative cervical spine, cervical spondylosis, whether it is osteophyte disc or ossified ligamentum flavum, or maybe subluxation associated, are the indications with OPLL, trauma tumor, and atlantoaxial dislocation also. And our number of cases, when I thoroughly had gone through now, are 391. In 500, we had included some other also cervical cases. So these were the exactly anterior approach cases. Others were more of AD posteriorly fused, and other cases, they have been eliminated. The most common site, as we all know, is C5-6 cervical disc, and these are the different levels which have been dealt with. These are clinical presentation we all know, and these are the imaging techniques for the diagnosis. These are the initial pictures when we had no video recording, etc., for the anterior cervical disc with platysma cut vertically after undermining the skin incision and reaching the disc and removing and putting in bone graft. This was the single level. You can see the bony fusion, and the bony fusion of the autologous bone was the best which we have experienced. But the only point was the second operation of taking out the bone was more painful, and the patient would always complain of that. Then came this peak, and simple peak we used to use, and then came peak prevail. You can see that. You can see then different type of peak and plate has been used here. You can see that multiple levels when there is cervical myelopathy. If the offending agent is anterior, one can do single level anterior approach, and at the same sitting you can do posterior decompression also, if the cervical myelopathy persists or at the same time. Then these are two levels. This was single level, different type of implant. These are two levels. Initially, we used to do two-level disc with bone graft at two levels, and this is all fused. You can see this was the disc. And then later on, this was a simple mesh cage which has been used with plate. And then with two levels, you can see this with the lordosis also disturbed. You can see this was expandable cage with plate. This is another type with two different levels with peak implant and peak prevail, and this is different type of expandable cage. In cases of OPLL, you can see the OPLL extending from here to here. And as in the morning I was discussing with Dr. Patkar that esophageal injury, when you do multiple levels, such type of operations, whether it is disc or it is OPLL, and if you do more than 3 levels or 4 levels, you have chance of, which I had in my series encountered 2 cases of esophageal injury and fistula. One patient died, and they take a lot of time in healing, and it's very difficult. So we later on stopped doing multiple levels OPLL, and means then later on we were doing only laminoplasty these days. You can see that this has been 2 levels have been done anteriorly. 1 level anteriorly it has been done, but 2 levels of OPLL has been removed, and then posteriorly it has been decompressed also. You can see another patient with this, but here we have done anteriorly in a different way, that we have not drilled the whole of the OPLL at 4 levels, but we have thinned it out and it is floating. So that would save from the injury also of trying to remove the adherent, this ossified ligament to the dura, and this is the large, you can see the expandable cage. Now this is different disease of Potts spine presented in different way with perivertebral and epidural abscess, and posteriorly cord compression you can see. And this is another patient with the Potts spine, and you can see the fusion. In the past, when we used to do multiple level, 4 level or something, we used to do bone graft with H plate, which was not compatible with MRI. But that time this was only available, these H plates were available. You can see at C2 also we had fixed the H plate. And this is multiple levels later on when we they used to get such expandable cage, the most modern of the plates and cage, etc. Then came the era of artificial disc, that because the fusion at multiple levels may impair with the motion segment or adjacent level disc disease. So the artificial disc was used. This was probably the first artificial disc used to come, was Prestige artificial disc those days. But then the studies suggest that whether it is ACDF or artificial disc, there is not much difference between the symptomatic adjacent segmental disease. The only thing is that one can return to work faster in artificial disc. These are some cases of trauma one can see with fusion. Here also this is trauma and fusion. And this is trauma to odontoid. You have already seen in the first half session with multiple, many lectures on odontoid fractures and their management. Then craniovertebral junction anomalies. You can see that nowadays everyone does posterior screw and plate. In the past we used to do transoral excision of the dents and posterior fixation by wire, then cable wire, and then later on this came. You can see this BI severe, and the whole of the dents has been removed. This is a tumor which is involving posterior elements as well as the anterior elements. You can see this, the whole bony more on the right side, left side mainly. And this is the CT scan. And this is after decompression and fixation with plate, and posteriorly the rod had been put on both sides. These are some complications of the implant that come out, extrusion of either graft or the implant. You can see the peak prevail coming out, this edge plate screw is coming out. You can see the bony fusion of the autologous graft is so well taken in the past. These are some complications which we and in the literature have been faced, like dysphagia, which is the most common one encounters because of retraction, edema, etc. Then wound hematoma, and sometimes you have to reopen because of the respiratory distress and other things, and pain. Recurrent laryngeal nerve, as just you have heard about it, which may be symptomatic, silent, and sometimes it is silent in 16% of the cases. So it has been recommended that those who have undergone some sort of thyroid surgery or some sort of cervical surgery must undergo laryngoscopic ENT checkup before you undertake them. Then dural tear may lead to meningitis or cutaneous CSF fistula. As I just mentioned about esophageal injury, and in the morning also we had discussed about this. So avoiding multiple levels anteriorly. Then neurological worsening in the form, whether because of cord contusion, radiculopathy, or C5 neuropathy, as you all are aware about it, C5 neuropathy. Horner's syndrome could be one. Then mechanical failure of instrumentation, extrusion of bone graft, a vertebral artery injury. We have not ever seen the carotid artery injury, but yes, vertebral artery injury we had seen in 3 of our cases. But we could get away by packing and the bleeding is stopped. And that is particularly you see when you drill laterally uncovertebral joint and go far lateral, or sometimes if there is tumor or something, you may injure them. And pseudoaneurysm formation, thrombosis, or AV fistula can form because of this. Thank you very much.
Thank you, Dr. Bhartiya. I think we are using so many implants in spine these days. For the last 3 decades, you have covered it very aptly. The very nice quote by Nicole, I think he said, she will rise with a spine of steel, roll like thunder, but she will rise. But I think we have to understand that, the less is always better in the spine surgery. The more, the less implant that we put, the better it is like. The paper is open for discussion. Any comments? Yeah, Dr. Patkar.
One of the most horrible implants is a distractable cage. A distractable cage is against all principles of spinal surgery. Basically, these cages are put inside. The end point has to be fusion. When you put a distractable cage, the amount of bone in the cage is very small, and plus when you open the cage to create the height, your bone is floating. For bone to grow actually what we grafting which you do is actually a sequestrum, because that does not have any blood supply. So that bone structure must be impacted into the joint, either the end plate above and end plate below. And if it is not impacted, you might as well throw it in the dustbin. In a distractable cage, what happens is, first of all, the center of the distractable cage, because there are two cylinders, is very narrow. And then, after you put it inside, you distract it, and those bone pieces are just floating in between. You will never get creeping substitution.
But what is said is like coiling, that you put few in a thrombosed aneurysm, if you put few coils, 2 coils, 3 coils, that initiates the thrombosis, and it initiates the thrombosis
Aneurysm
and the whole
bone
thing.
Aneurysm and bone are completely different. And you might as well put some bone chips in a fracture and hope for it to heal. That is against principles of how to do orthopedic surgery.
All right, I think we can
No, but
discuss it later.
that is, you are right, that there is nothing better than the autologous bone
No,
graft.
I'm not saying nothing, but I feel that the mesh cage is a very good option, because you pack a lot of bone, and that bone is in contact with the end plate of the. Very important in spinal surgery is the gardening, making the bone fuse, making holes in the end plates from where the bone will grow into what you have grafted. If your bone graft is floating, it's never going.
No, your bone graft should not float. That is the idea, that you have to fix it, fuse it snugly. It has to be fused. And usually before this, you used to make 2 slots in the upper vertebra also and the lower vertebra also.
When you open the cage, your bone graft is no longer in contact with the bone.
You don't distract it too much. You fit it, and then you just fix it with the plate also.
All
So
right,
how
I think
you showed,
we
how
have a
you
tea
showed,
break for that. We can discuss it over the tea break later.
Yes, sir. Just
Thank you. Sir,
Dr.
please.
Patkar, what he showed was when he was putting 2 screws in the odontoid dents, C1, C2 there, in the fracture, the first screw, the second screw, and the third screw, the fractured fragment from above comes below. Then the third screw that sticks to that. Similar is the thing that once you have put in the cage, and when you are screwing, they will come closer. So
Thank
that
you so
may be
much.
the-
Thank you so much.
Thank you. Bye-bye.
Thank you, sir. Thank you. Next, I call upon Dr. Sushil Patkar. He'll be sharing his experience on cervical OPLL, decision making, and novel technique of vertebral advancement. Dr. Patkar is Director of Neurosurgery at Pune Hospital and Research Center, Pune.
Thank you, Professor Jha, and for this opportunity to come here and speak among so many senior stalwarts and to share my little work and some students. Maybe I can influence their minds into what I like to talk about spinal surgery. OPLL, when I began in neurosurgery, I'm not very old and I'm not very young, but when I began in neurosurgery, OPLL was not so common, it was not heard of. That time we used to operate on myelograms. I came in that cusp period when CT scan had yet to come, MRI had to come. And as I started training, we used to do on myelograms all decisions. We did the myelograms ourselves. And then suddenly people started talking about OPLL when the CT scan came. Till then, myelopathy was myelopathy. It was because of cervical spondylotic myelopathy. There was nothing like OPLL when I started. When CT scan came, when MRI came in 90s, that is the time people started talking about OPLL. of course, my teachers and from whom I learned some spinal surgery of Dr. Ramani and one person I admire, Volker Sonntag. Of course, Atul I always admire. So OPLL, there are various classifications, various theories. It came out from Japan. Whether it was an attempt to stabilize the spine, whether it was a viral infection, maybe it was related to that habit of the Japanese to keep on hike. They kept on bending and moving their cervical spine, and therefore you'll find in the eastern part of the world this disease came, and the Americans were unaware. There were various classifications about a type of OPLL and where it is, how it is hill type, or whether it is, all this is there in the books. I will not waste time on all this. It has got certain surgical implications. For example, to drill out, when you want to do anterior surgery, you must know what kind of OPLL you're dealing with and how much you drill, what is the extent. What exactly, people try to treat OPLL like cervical spondylotic myelopathy, which is not correct. And I take this opportunity for you to read Dr. Goel's literature. His recent work on OPLL is the outcome of instability, whatever it is. But OPLL is not to be treated like cervical spondylotic myelopathy. Means what? That in cervical spondylotic myelopathy, there's no argument that you have to do anterior surgery. But in OPLL, it is a long-standing process. Over years, the spinal cord gets stretched, the roots get stretched. So even if you do a laminectomy or a laminoplasty from behind, you get as good results, unlike spondylotic myelopathy. You're not going to get good result in spondylotic myelopathy if there's ventral compression by doing laminectomy. So it is a deformative stress which is important. This concept was put forth by Vaccaro, and you must read his work on deformative stress. Anyway, so is it an abnormal attempt at stabilization? And therefore, is stabilization more important in treatment of OPLL, or is decompression more important? I'm still not convinced with either of them. But one thing is sure, that once the patient starts getting symptoms, you better treat the patient. Once the patient has got symptoms, the course is invariably downhill. And sometimes, a trivial fall can worsen the patient, because there's a big dilemma. Patient sometimes comes to you with OPLL, little neurological deficit, whether to operate or not to operate, whether to continue observation. So literature says, if you make use of we cannot use literature to make an indication for the patient, but we should answer ourselves by reading up, by seeing what other people have published, and of course our own results and what we are capable of doing. Just because somebody else can do 3-level OPL anteriorly, one should not put his hands if you are not trained at doing good microsurgery. Another interesting thing about OPLL is that the more longer the OPLL, the more kyphotic the spine, lordotic the spine. And you get away with laminectomy. The more extensive the OPLL, you will find invariably the spine is lordotic. Also, we have to remember that OPLL is a progressive disease. Whether you do laminectomy, whether you do laminoplasty, or whether you do anterior cervical spinal surgery. Now see this patient which I had operated in 2011. Then that was post-op, he was decompressed. In 2016, 2017, and 2018, the OPLL is just progressing. But he refuses surgery, though his myelopathy has worsened. He lost faith in me and lost faith in neurosurgery. So what are the aims when you treat OPLL? That you should do neural decompression, look at the spinal alignment, and get a successful fixation and fusion. The morbidity is related to the age, the medical condition, and the duration of the surgery. Whether to treat, not to treat, maybe we'll watch. Now this is an example of multi-level OPLL. You can see how it is from above downwards. And whether nature is trying to stabilize the spine, which what Dr. Goel keeps on saying, if you see the Western literature, it was focused on cervical spondylotic myelopathy because they didn't have the disease there. And they started getting their complications of failure of implants and complications related to anterior decompression, dural tears. At the same time, in the Eastern world, they focused on doing the surgery from behind, like Hirabayashi, etc. And they pioneered the work on opening up the spine from behind, and they felt that the roots are already stretched, so there is no need to go and remove the OPLL, just make more space for the cord, and the cord will migrate backwards, and they showed it with various techniques of their different kinds of laminoplasties. But one thing was sure, that in spite of whatever you do from behind, there's always instability is an issue. Always. When you do laminectomy, whether you do laminectomy, it's a myth that laminoplasty prevents instability. Laminoplasty also causes instability. So there's laminectomy, laminoplasty plus lateral mass fixation. That is probably the kind of gold standard, midline kind of approach. So everybody knows laminectomy is easy, simple, anybody can do it. Laminoplasty is the posterior elements are preserved, they say, but I tell you, anybody who does laminoplasty, they never tell you in the operative steps that you have to cut the ligamentum flavum above and below. And when you do that, the stability is gone. Just reflecting you cannot reflect the bone flap till you cut the ligamentum flavum at the upper end and lower end. And when you do that, you have finished the posterior tension band. So therefore, I do not feel that laminoplasty is a very great operation, and that what the claims which are made are probably it prevents a laminectomy membrane and nothing beyond that. So there are various implants available. These are some examples of laminectomy and laminoplasty. Laminoplasty has its own problems. If you review literature, they are comparable, both laminectomy and laminoplasty. There are many myths of laminoplasty which have been sold by the instrument manufacturers, by maybe Japanese surgeons. They keep on talking about it and we keep on swallowing it. But there is no difference between laminectomy and laminoplasty, and literature is flooded with such articles. Spinal alignment, that is very important while taking decision making in surgery for spondylotic for OPLL. The kyphosis correlates to poor outcome. Disease progression takes place in spite of decompression. Good cardining and is the secret for good fusion. This, I think, is a very important message. Now look at this case. This patient has got OPLL. The OPLL is extended up. After the decompression, also the OPLL is extended. And even you will see in the cord, the signal changes have been progressive, though there is a good decompression. So whenever there is a deformative stress, the patient can continue to worsen in spite of a good decompression in the MRI. We must know this, and this must be discussed with the patient, because otherwise the patient gets disillusioned with your surgery. Sagittal balance, I have already talked about it. Now, how much of the spinal canal is being occupied by the OPLL is another deciding factor as to whether to do anterior surgery or posterior surgery. Ballpark average, they say that more than 50% of occupation is, then you must offer anterior surgery if it is a short segment. If it is a long multi-segment OPL, of course, still posterior surgery is done. Anterior surgery, there is no doubt that it has better outcomes as far as neurology is concerned, but then it has got its own complications. It's long-standing. You require a lot of time for doing the operation. There's a lot of blood loss. So there are various systemic reviews in literature. The operating time is longer. The infection rates are higher. Operating time and blood loss are directly correlated with the final outcome. And in the end, you'll find that at 5 years, the results are same. So there are various complications of anterior surgery. And if you notice in the complication, the most important dreaded complication for neurosurgeon is the damage to the spinal cord by the drill or dural tear. So neurosurgeons, when they talk about anterior surgery for OPL, these are two things which are going on in the back of your mind. I'll tell you why I'm stressing on this. And C5 root injury, etc., etc. So overall complication rate is 11 to 27%. Very high. 30% of the patients can get complications while doing anterior surgery. Anterior plating will shift the center of rotation to the anterior plate surface, and graft subsidence will transfer all the compressing loads to the plate, and the plate will eventually fracture. Multiple surgeries. There's a very high incidence of second surgery when you do anterior surgery because of implant failure, because of CSF leak, because of infection. So people started focusing on this surgery. Do decompression from behind and do lateral mass fixation. So I kept on, I was thinking about this for many years, why we are not able to do anterior surgery because of these two problems, that is the damage because of decompression and the CSF leak. So what I will do is, I will go straight to show you because my time is running out. So these are various kinds of cases. Of course, I have published my work earlier in WFNS textbook, how to do the correct way of plating, the correct way of fixation. Then I had written with Dr. in Neurology India also. But this new concept fascinated. In fact, I had presented my work at APCSS in New Delhi. The spine, Dr. what is his name, from Ganga Institute had called me, and I had done my few cases. And then immediately after 2 years, I was trying to do more cases, but somebody else also published this. But I've got my own way of doing it, how to advance the vertebral bodies in the front. There are various ways. One is to put cages in between. So you recreate the kind of K line. So this cord compression is relieved, making simple task difficult, And of course, Dr. Goel does not believe in all this. So this is my technique. You can see that the vertebra is advanced forward by a specialized implant, again made by Jeon for me, where I drill the vertebra halfway. This is done for both cervical spondylosis as well as OPLL. So you can see this another example of cervical spondylotic myelopathy, where the entire 3 vertebrae are moved forward and the spinal cord compression is relieved without taking the drill onto the dura. And that fear of damaging the dura, causing CSF leak or causing drill injury is negated. This is another example how you can see how the vertebra is moved forward. You can see this is a case pre-op and this is the case post-op, and the spinal canal is increased by almost 5 mm. So this is the technique essentially. It is very simple. The concept is that this is the OPLL. Drill up to say half the vertebral body, and then there are reduction screws. The plate is fixed on top and below, and there are reduction screws which are passed. And as you tighten it, they pull the vertebra with the OPLL forward. So you don't have to go and spend time on drilling on the OPLL. I will show the video so it will look, you can see it better in the video. I feel it is a very simple operation if you conceptualize what is to be done, and one important gadget which is required for this is a bone saw, but it can be done with a micro drill also. It's not necessary that you should have a bone saw only. So if you look at the uncinate process where the bone turns upward, that is the lateral boundary beyond which will be the vertebral artery. So after exposing, this is the OPLL. You take the micro drill and drill off half the vertebra. This is the landmark, the uncinate process. If you don't go beyond it, you are not going to damage the vertebra. This is the bone saw. With the bone saw, you make a vertical cut. It stops when it reaches the dura. It is very good for hill type of this or flat OPLL. Then you remove the disc above and below. Pack it with bone chips. You should have bleeding end plates. Pack it with bone chips. I have not done more than 2 levels so far. There's a specialized plate has been made to which you can fix it. And through it, these special screws are passed, which has got a place where they can break off. The vertebra is pulled forward, the central portion, and this can be broken off. Now I've devised new screws where you don't have to break off. The screw is passed directly through the plate first, and then the upper and lower screws are tightened. So this is how it moves the OPLL. So the entire problem of anterior surgery, especially for 1 or 2 levels at least, is out of window. Now you see this example. This was 8.6 mm. This was the pre-op MRI. And see this, how it has moved forward. The bone graft has now become 11.6 mm. This is a case of, like I said, spondylotic myelopathy, where the same principle can be used for advancing the vertebra in the front. Where is this gone? I don't know. Yeah. So I think in any case of OPLL, these 3 questions are very important before you take a decision on operating OPLL. Medical fitness of the patient. You know, these patients are elderly. You cannot apply the same technique for all patients. The most important thing I feel for these patients is their breath holding count and their capacity to hold their breath and the tidal volume because many of them, they come with bad neurology, and the operation can look fantastic, and you can end up with a patient who's on the ventilator, and then thank you very much. Your own surgical skill, you must know how good and what you can do. Just because somebody else is doing corpectomy, somebody else is doing C1, C2 fixation for OPLL, you should know whether you can do it so easily. He can do it. Maybe somebody else can do it. And the level of technology available to you, you must have good instruments. At least the basic instrument, a good drill, a good C-arm in the theater. Otherwise, don't attempt. I've seen many times OPLL surgery being done in small nursing homes with disasters and then being shifted to bigger centers. And then there are sometimes people who may show OPLL, some cord compression, don't offer surgery from them. Remember, from too much zeal for what is new and contempt for what is old, from keeping knowledge before experience, science before art, and making the cure more painful than its endurance, good Lord, deliver us. Thank you very much.
Thank you so much. We can have one quick comment or a question.
Is this OPLL not stuck to the dura?
The CT scan and the CT scan can sometimes give an indication. When there's a double layering, then it is stuck to the dura. But usually it is not stuck to the dura. If you see double layering on the CT scan, rest assured it is going to be stuck to the dura. But most of the time the OPLL is not stuck to the dura.
Then is your technique effective in those cases?
Yes, because it will pull the dura also in the front.
It will pull the dura.
It will pull the dura. The cord is far away. Your idea is to get the compression. Yes. So when you pull the vertebra in the front, it will pull the dura
also.
With it.
Okay, thank you.
And pulling the body.
I can't hear. Start again.
Sir, when you put the compression screw and pulling the body, so vertebra is a single unit. So when you're pulling the body, then particles will come and
No, you're cut on the sides, no? I showed that you first cut on the sides. Without cutting on the sides, you cannot put the vertebra in the front, my dear.
Okay, sir. That's all.
Looks very good and on animation, but I don't know how.
I showed some examples.
No, but once you put the screw to pull the vertebra, half of the vertebra back, then how does it work? Once you screw inside, most of it is a cancellous bone.
The trick is don't make the cuts till you have finished drilling half of the vertebra.
No, but most of it is a cancellous bone. It will not hold the screw as
you have to go
as when you take it back.
You have to go beyond the posterior cortex. You have to go up till the OPLL. You must not just put it in the cancellous bone.
Small comment just. Dr. Patkar showed one slide.
He got an opportunity to catch me, huh?
No, it's not. Just one slide he showed that how to, don't make the things complicated. So what I felt after this was, are you making it easy or complicating it?
You have to do it. The taste of the pudding is in tasting it.
Unless you are a neurosurgeon, why you should be afraid of drilling it? You should not be afraid of drilling
I am not afraid of drilling, my dear. I am saying you must always try to find a simpler and easier solution to a complex problem. Fear is not my problem.
That's why I said in my first half that making it more complicated.
Every operation evolves towards simplicity. You must make every operation simpler and simpler and simpler, so you hand over the next generation a better procedure.
Excellent.
Maybe the last question? Or?
Looking at that, it's just, I think it's fine for single level.
Yes, I agree to that.
Because, the slide you showed, you've still got OPLL above and below the level of the vertebrectomy. I think
it is good for segmental level.
Yeah.
It is good for segmental OPL. Maybe it is good for two segmental level OPLLs. But it may not be very good for a continuous OPLL.
So you've done it for two levels. You don't,
two levels I have done, but both were segmental. Or maybe cervical spondylotic myelopathy, where it is only at the level of the disc. There's something known as early onset OPLL. That is cervical spondylotic myelopathy going on to become OPL, the osteophyte becoming ossified and calcified. That is called early onset OPLL. Yes, sir.
Can I ask one technical question, sir, regarding this?
Please do, but...
Yes. Wonderful technique, sir, and as you are very well known and very well published, this thing also, you've always been talking about anterior approaches to the upper cervical spine. My one technical question is, when you have drilled the vertebral body and cut the vertebral body on the sides, that anterior column is sort of a loose segment. Now, how do you deal with this loose segment when you are trying to, put in a screw inside and trying to deliver it out? Haven't you faced any problem of that loose fragment of the cancellous bone slipping inside and causing all the more damage?
Process in evolution. Now what I do, after I finish drilling and cutting the sides, I first pass the screws through the plate before cutting the sides. I will pass the screw through the center of the plate, then fix the plate and put bone chips into the disc space and finally pull the vertebral block in the front. And now the new one comes where you don't need to break the screws. The screws are passed directly through the center of the plate into the vertebra up to the posterior cortex. It's still work in evolution, but it is doable. That is the point I'm trying to make.
What he is asking is that this fragment is still loose. That's what you are telling.
No,
No.
I'm asking
During
that
the reduction.
during the advancement, when we are tightening the screw, that there is a possibility that this loose fragment of the bone might sink in rather than being pulled out.
It doesn't.
But that fragment is entirely loose.
You'll disconnect it after you've fixed it with the screws.
No, but then when we apply the plate, do we have the space enough to drill it on
Yes.
the sides?
The plate has got only a center place to pass the screws. On the sides, you've got adequate. If you want, I can restart the video.
No, I mean, in that case, it is doable. But I mean, that you showed is first drill it and
Yes,
cut it.
like
and then-
the video was made before. You keep on, getting the idea, make it do better and better. And now the newer screws, you don't have to break the screws also.
Thank
Dr. Goel, you wanted to say something. You bend forward and then again you pushed back. No?
Okay, thank you, Dr. Sushil.
Thank you.
Now I'll invite Dr. Atul Goel. He doesn't need any introduction. The master of craniovertebral junction. He is not a man with the technique. He is a man with the thoughts and some philosophy. That is why a neurosurgeon has to be a thoughtful person, philosopher with the knowledge, then only the success will come. And now he will be talking on cervical, he will be talking evolving concept in spinal instability. Dear Atul, please.
Thank you, Dr. Jha, for inviting me. Your institute, AIMS, Jodhpur, is fantastic, fantastic place, I hope. And I wish and I want that you continue your fascinating and beautiful work in this great institution. I am going to present before you, my dear friends, a revolution. An absolute revolution in spine surgery. When I say revolution, it is quite an egoistic word, quite a dominant word, but whether it is egoistic, whether it is dominant, every sentence that I will speak has been published several times. And there are more than 150 articles of mine on this subject, which I am going to talk. If you realize the entire world of spine deals with one issue, and that issue is decompression. Compression is the issue, decompression is the treatment. I want to negate this thought, and I want to take you differently in a different direction. Compression is not the issue. Decompression is never the treatment. Quite a dramatic statement, right? Compression is always secondary. Compression is always protective. Compression is always reversible. Compression in degenerative spine and in OPLL, these statements have never been made in the literature, are secondary to an unstable spine. Human body is different than any other animal on the planet. We stand. And when we stand, our entire musculature, if you realize, is focused on the facets. Not one muscle is focused on the disc or on the vertebral body. When the muscles become weak, there is facetal listhesis. And this facetal listhesis cannot be seen radiologically. And this listhesis is the origin of spinal spondylotic degeneration, not the disc. If you read the literature for the last 100 years, every article will say disc water reduction, disc height reduction is the beginning of spinal degeneration. I am saying no. It is your muscle weakness which leads to subtle instability, leads to degeneration of spine, a complete revolution. Not only this, I am saying that OPLL is a manifestation of long-standing instability. This statement has never been made about instability in OPLL, in degenerative spine. Vertical facetal instability. This is a brand new concept in spine surgery. Or telescoping of the spines, of the spinal segments. If you see your grandfather, his height is lesser than yours, but grandfather must be much taller than you when he was young. There is telescoping of the spine. There is beginning of vertical facetal instability and a beginning of spinal degeneration. I introduce this concept to you, my dear friends, of vertical facetal instability. I introduce a brand new dynamic concept, of chronic instability of atlantoaxial joint due to muscle weakness without any radiological manifestation. There may be no question of any instability on atlantoaxial joint, but it is unstable. That concept has the potential for others. For me, it is already done to completely revolutionize craniovertebral junction surgery. Central or axial atlantoaxial instability. So if you have heard me or you have read my papers, I have been talking of this instability as a cause of basilar invagination. Unfortunately, this pointer is not working. So I have been talking of this instability C1 over C2 listhesis as a cause of basilar invagination. If you have read the literature, nowhere in the literature instability was the cause of basilar invagination till we produced this concept. Stabilization. Listhesis is the problem, stabilization is the treatment. Decompression is a negative operation. Then we came into this type 2, that there can be this kind of basilar invagination. Whole world today is doing decompression. I am saying it is a negative operation in the presence of facetal instability type 2. When the facet of C1 goes behind the facet of C2, stabilization is the treatment. Decompression is a negative operation. Then I go further. Even when the facets are in alignment, there is no atlantodental interval disturbance, presence of chiari, presence of basilar invagination, presence of assimilation of atlas, presence of syringomyelia are absolute indicators of chronic, maybe 20-year, 30-year dislocation, subtle, progressive, disabling, ultimately killing issues of central instability. Stabilization is the treatment. So this concept of central instability, you see, so if you read this, you see all bifid, C2-3, Klippel file, platybasia, kyphoscoliosis, torticollis. If you go to US today, believe me, for all these entities, decompression is the treatment. And I am telling you, for all these entities, there is only one and only one positive treatment, that is atlantoaxial instability, because all these manifestations are secondary to chronic and long-standing. They are protective. They are indicators of atlantoaxial instability, and they are reversible. Believe me, when I talk like this, all these sentences are heavily published in the literature. Don't think that I am just making a story. Now I want to talk on degenerative spine. And if you have read my several articles on the subject, including in the book on Sweet and Smedek, I have a lot of literature where I have talked of anterior surgery, corpectomy, and all these kind of things. This is from my book chapter of Sweet and Smedek, which is a very well-known book in neurosurgery, and anterior surgery, osteophyte resection, and all those things I have talked. These pictures are from my book chapter. And I had talked about these kind of screws, tricortical screws. So I know what is anterior surgery. I have done anterior surgery, and I have evaluated anterior surgery. But today what I am saying is what I am saying today. Degenerative arthritis of the craniovertebral junction has never been discussed in the literature. You ask me, I tell you, atlantoaxial joint is the most mobile joint of the body. Atlantoaxial degeneration is the #1 degeneration in the spine. We talk of C5, C6, we talk of C4, 5. Have you ever heard of C1, C2? I am saying most common form of degeneration is C1, C2 degeneration, most neglected, most undertreated clinical entity. So I had written this paper a long time ago where I had talked about degeneration of craniovertebral junction. I want you, my dear friends, carefully look at this slide, carefully. Reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formation. These are not primary events. These are secondary to vertical instability. These are secondary, these are protective, and these are reversible. These need not be handled. And if you handle by decompression, you are doing an absolutely negative operation in an unstable situation. Presence of ossification in the apical ligament, ossification here, osteophyte formation here is not a primary event. They are secondary, they are protective, they are reversible, they have to be revered, they have to be acknowledged, not removed. You stabilize the issue and the matter is closed. And the matter is closed for good. And the recovery that you will see, you have never seen by decompression, that you take it from me. Presence of retroodontoid pseudotumor. The whole world was doing transoral surgery or lateral surgery for this clinical entity. Many of you are young, you don't know. But you see the literature, whole world was doing. We said for the first time in the literature that these are secondary, these are indicators of unstable atlantoaxial joint, and these need to be treated by atlantoaxial stabilization, and this will disappear. And there are several publications. Now, I have to tell you that many people in the world, particularly my friends from China, are doing only fixation for this problem, not from India still. So retroodontoid pseudotumor is like an osteophyte indicating atlantoaxial instability. Stabilization is the treatment, and this was the first article on this subject. Retroodontoid cyst is an indicator of unstable atlantoaxial joint. You don't have to remove the cyst. It's a negative operation. Cyst removal is very easy. You puncture the cyst, I remove the cyst. That is negative. It is an indicator of atlantoaxial instability. Stabilization is the treatment, and this will spontaneously disappear. And we have got several cases like this. Retro C2 body cyst in the presence of os odontoideum is an indicator of unstable spine. You know, when I talk in very few sentences, particularly in the US, the whole of US is doing transoral decompression till today. The whole of US is doing transoral and occipitocervical for this entity today. Completely nonsense. This is an indicator of atlantoaxial instability. Stabilization is the treatment, and this will disappear spontaneously. And these kind of things, this patient treated for tuberculosis and all. You have to understand what is the issue and what is the treatment. If you want to know more about what I am saying, you please read this article, beautiful article in the literature. Pseudopanus, rheumatoid panus, the whole world was doing transoral surgery for panus. And I am saying for the first time in the literature that panus is due to vertical facetal instability. Is secondary, is buckling of ligament. You stabilize, it will disappear. And it can disappear in the immediate postoperative period. Now, my dear, I want a little bit more time. Can you give me? So, you know, okay, you stop me whenever you have to stop me, but I will request my dear friend Jha to give me additional lecture later, because I want to, because these are young people, why you want to listen to the old rut again and again and listen to some brand new thoughts? So now You see there is basilar invagination is due to listhesis. Nobody has talked about facetal listhesis in degenerative spine. Very common and always, not common, always. Carefully see this slide, my dear. What are you looking at phone here? Reduction in the intervertebral joint. You're seeing reduction in the joint space. Buckling of these ligaments, bulging of these discs, osteophyte formation, bulging of these discs are not primary issues. They are secondary to vertical spinal instability. They are secondary, they are protective, and they are reversible. So some 15 years ago, we introduced this concept of facetal distraction as the treatment for this problem. And you introduce a facet distractor, and immediate post-operative, the entire complex, buckling ligament, ligamentum flavum buckling, disc herniation, disc, everything will improve in the immediate post-operative period without any question. Now I'll show you one picture only. You see the ligamentum flavum buckling and posterior longitudinal ligament buckling, and this is immediate post-operative, distract. There is no decompression in this. Decompression is a negative operation for all spinal problems. So this was my article, which was published as a cover page of Journal of Neurosurgery several years ago. I know many of you have not read this. Same concept we introduced for lumbar problem. You see this kind of lumbar herniations and all. We said that they are not primary. You distract, there is no need for decompression, and this was published in Journal of Neurosurgery about 15 years ago. Decompression of compressed or deformed neural structure has been the basis of surgical treatment for several decades. We introduced in 2013 a brand new concept that instability is the issue and stabilization is the treatment for degenerative spine. And no even secondary distraction is not necessary. So this was my paper in 2013, and more recently in 2020, I wrote that only fixation, no decompression, and my fixation is by Camille's technique, transarticular. Believe me, for 5-level fixation, my assistant will open, and within 10 minutes, I will do 5-level fixation. And you believe me, for last 15 years, I'm doing this operation. Such a straightforward operation, no complications, zero. You do 5-level anterior fixation, 100%. Even the topmost spine surgeon of the world, complication rate, my own personal friend, more than 60% complication in more than 3-level decompression. You do 5-level trans, no complication. And dramatic result. You please read my article on this subject, and you will be flabbergasted by these results. And you see the beauty. You see this multi-level, no decompression, no corpectomy, no discoidectomy. You do only fixation transarticular. I do Camille's technique in 5 minutes or 10 minutes. And you see after 1.5 years, this completely disappears. This is after 1.5 years radiological magic, but clinical magic will be in the evening of the operation after the patient gets up from anesthesia. And we have got several patients like this. I'm not sure, decompression, laminectomy, laminoplasty. Nobody in the literature has ever said that instability is the primary issue in these cases and stabilization is the treatment. This problem, these are considered to be pathological, these are considered to be compressive, these are considered to be dangerous. The whole spine surgery is focused on removal of osteophytes. So we started looking at degenerative cervical myelopathy in a different perspective. Instability is the cause of symptoms, and stabilization is the treatment. Another fascinating statement, even for OPLL, it is not neural deformation or compression, but instability is the cause of symptoms. Most important is we have to find out which segments are unstable. You cannot go and fix a level after level. And read this article. Now you see this beautiful imaging, there are 2 levels of compression, but I have done 4 levels of fixation. And you see the image. Which levels have to be fixed, which level have to be addressed, forms the basis of treatment for cervical degeneration and for lumbar degeneration. Decompression is not the treatment. So here there are many cases like this. You see this is another case, and this is, I have got cases after cases of cases, and I belong to a public institution. There are fellows and residents surrounding me all the time. Like my dear friend said, that I asked the question to my colleague who was sitting by my side. I am saying no complication, but this colleague was saying complication after complication. My fellows are there to say and to corroborate what I'm saying. Beautiful, believe me, you try to understand. You don't be fixed. Don't be fixed with these cages and distraction cages which are thousands of rupees. These screws are 10 rupees screws. Beautiful. Another fascinating issue which nobody in the world has ever discussed. Have you ever heard of multi-level spinal degeneration? You talk of C5, C6, C4, 5. Never you have talked of C1, C2. I'm saying C1, C2 instability is a common associate of multi-segmental degeneration. Central instability is the issue, and stabilization, inclusion of C1, C2 in your fixation construct is mandatory. So you see here, there is instability here, multi-level, no compression. In my eyes, compression is not the issue. And in my eyes, decompression for such issues is a completely negative operation. Stabilization that includes C1, C2 is the issue. When the patient comes on a wheelchair, when a patient comes on a stretcher with multi-segmental degeneration, atlantoaxial instability is more often than not associated. You include the C1, C2, and you can send the patient walking. If you read my article on this subject, 65 or some patients have come on a wheelchair, and out of them, a big number, I'm not sure exactly, but more than 40 patients have come after 1 month walking. So you can imagine, and there is no decompression. Think about it. No need to get excited, and no need to get emotional, and no need to get fixed. You think about it. So multi-level spinal degeneration, atlantoaxial instability is a very common associate. And there are ways to do atlantoaxial fixation in a different format, not like directly C1, C2, which I have published. Similar concept, quite a dramatic concept, lumbar canal stenosis. I am saying it is not, the canal is not stenosed. There are multi-segmental muscle weakness causing vertical spinal instability. You read this article which is published in Neurosurgical Focus. I am saying that analyzing the role of stabilization and futility of decompression in lumbar canal stenosis, I am saying stenosis is a wrong term. When the stenosis is the term, decompression is the treatment. Stenosis is a horrible term for lumbar canal stenosis. Canal stenosis is a result of vertical facetal instability. Stabilization is the treatment and no decompression. And we have got several cases in this. Now the question is do we need to remove the osteophytes in degenerative spine? I'm saying no. I'm saying it is negative to remove degenerative spine. And you please read this article of mine where I have evaluated only fixation, what happens to osteophytes, and you will see some magical clinical and radiological outcome. You see these osteophytes, and you see this is after a period of time. The whole scenario changes. Another thing, my dear Shashank will be interested. Deformities, Shashank, listen. I heard your lecture in Blackpool just 1 week ago. Deformities are not primary events. Deformity is secondary to multi-segmental spinal instability, and stabilization is the treatment. Any kind of corpectomy, any kind of removal of this bone and that bone is an absolute negative clinical surgical procedure. And I have divided into 3 groups my cases, and you read this article on what my philosophy on degenerative spine is there. Another quite a, maybe controversial for you, maybe controversial for the world. I'm sure it is controversial for the world. But what I'm saying is what I have experienced and what I have published on several occasions. Prolapsed disc is a result of unstable spine, or prolapsed disc causes instability of the spine. That is why we give collar and the person is relieved. That is why we give belt and the person is relieved. Stabilization is the treatment. There is no need to remove the disc. This is for subaxial spinal facet. The whole world will do anterior surgery and remove this and then do fixation. Some will say no fixation. We know all those things. But you do only fixation and the person will dramatically improve and the disc will dramatically disappear in few days. And this is not just what I'm speaking. This is all published in the topmost journals of neurosurgery. This is published in World Neurosurgery, facetal fixation orthodesis for cervical radiculopathy. Radiculopathy. Similar concept we introduced for lumbar disc. You do fixation and close the issue. There is no need to remove the disc, and the disc will disappear, and the patient will improve dramatically. There are various issues to identify which segments are unstable, which segments have to be fused. There is disc on one level, but the adjoining segment may also be unstable, which needs fixation. So we have to know all those things.
Atul,
Before I go, my dear friends, listen to this beautiful, magical thing for the last time, because Atul Goel is here now with you. Just enjoy it. Ossification of posterior longitudinal ligament. Nobody in the world has ever said, my dear Sushil Patkar, nobody has ever said that stabilization should be included in the treatment protocol. People say that you do disc corpectomy. This corpectomy can make the thing unstable. That is why you fix. You do laminectomy. It can produce instability in the long run. That is why you fix. I am saying you fix. And there is no need to do anything to the OPLL because OPLL is secondary to chronic, long-standing instability. Stabilization is the treatment. More often than not, atlantoaxial joint is unstable in these cases, and you have to include atlantoaxial joint in your fixation construct. And you see the magic. And you see a magic with zero complication. And with such a straightforward, simple operation, I do in 10 minutes, 5 level or 4 level, and you have to just see, or you know what, I am having visitors from all over the world, but Jodhpur is not far. Many of you are from Jodhpur. Come and enjoy some magic. Magic. So is only stabilization the ideal treatment for OPLL? My answer is absolute yes. And this week, I recently published my experience with 52 cases. Now we have, this is about 4-year publication, and this is the magic. No corpectomy, no laminectomy, no laminoplasty, no OPLL resection, no weak dura or segmental OPLL or any kind of segment. You just do fixation. No laminectomy and see the magic. What is the harm? Suppose your treatment fails, you can come from front. You have already fixed. You can do it if you fail. Suppose you fail. I have never failed with this concept. And these are the OPLLs where you have to include atlantoaxial joint in your fixation construct. Atlantoaxial joint instability is a common association of OPLL. Remember it. Don't ignore just because I am a local Mumbai guy or something. The same statements were made by some European or some high-five language and all those. You said, yeah, very good, very good. But now Atul Goel is saying what? But a revolution is here, and revolution is here to stay. Because I am talking not on the basis of 1 or 2 here and there cases. I used to work in the busiest institute, the divine institute of this country for such 38 years, for 25 years I was head of department. No question about it, no question. So atlantoaxial instability is association, you have to include this, and can it revolutionize the treatment? Can it revolutionize? When I make this statement, it's a published statement. Don't think that I am just making here and running away. This is published in the literature. Can decompression for degenerative spine disappear from the scene? I am demolished transoral surgery. I demolished. I am saying I will soon demolish foramen magnum decompression surgery. I will demolish. And I am telling you today, I will demolish anterior cervical surgery. I am saying today, I will demolish laminectomy and laminoplasty sooner than later. Too many aggressive statements, but do enjoy. Compression, my dear friends, is never primary. Decompression is never the treatment. Thank you very much. Why the claps are so subdued? Why the claps are so... Are you hesitant? Are you afraid of your boss sitting here or somebody sitting here? No, 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 I don't agree. Don't agree.
Only one statement. Keep on thinking, thinking, and thinking, and find a cause to every problem with the thought process. If you keep on improving the knowledge, the treatment will come.
My dear, my most respected teacher in neurosurgery, you know Dr. Sunil Pandya.
I know that.
And you don't know Dr. Manu Kothari. Dr. Manu Kothari, who was my philosophical guide for 30 years of my life. He told me one thing. I used to sit down in front of his feet every day. He told me one little idea is bigger than 1,000 people operating for 1,000 years. Don't admonish or criticize or ridicule an idea. This is my suggestion to you. Thank you very much.
Sir. Sir, may I ask a few things? Sir, the extension of your concept philosophy is the joint instability is the cause. Then what is the cause of joint instability?
Muscle weakness.
Why don't you think about strengthening the muscle, not...
We have to do that. We have to think of only that.
And
we have to do exercise, running, yoga, jogging. If you are doing jogging, if you have that kind of beautiful body like you have, you will never have degenerative spine. If you are bloated like this, and if you are... You know what? Somebody recently... I am giving this lecture all over the place. Somebody recently started arguing with me. And I said, as long as you are horizontally big, your vertical will be worse. So you don't be horizontally big, your vertical will be strong.
And one more thing, what is the normal range of any joint movement? Suppose C1, C2. If in Chiari malformation we do dynamic flexion extension, normally there must be some movement. And how do we know that this is abnormal?
So, you know, also, Dr. Deepak, you are my host today, and I'm very jealous of you that you are heading such a wonderful institute. I am jealous of you that I cannot be in your place at this point of time. Such a wonderful, great institute, and I wish you all the best. What your question was, I forgot. The normal range, I am telling you, these are atlantoaxial, this is central instability, this is chronic, subtle, long-standing instability for 20 years where the nature comes in picture. There is a divinity, there is nature protection. You see, where there is acute injury, there is a stiffness of neck, there is short neck of neck, there is stiff muscles. But if there is a instability for 25 years, this shortening, this stiffness becomes short neck. And there are various bony abnormalities which the entire world considers pathological. The short neck is not pathological. Short neck torticollis is not pathological. I am going to give one more lecture on craniovertebral junction and issues which you will like to hear tomorrow as to what magic is there of craniovertebral junction. I want a better chairman tomorrow.
We'll give you Dr. Patkar as the chairman tomorrow.
Now I'll invite Dr. Narasinga, cervical lamino-foraminotomy. I remember him from the Nimans only. I still call him ex-Professor Nimans as compared to Visakhapatnam.
Thank you, sir. Thank you for that kind introduction. And Definitely, I enjoyed Dr. Goel's talk, as every one of us, and it is so difficult really to present after Goel. I'll try to do my own efforts to do the justice. So my talk is simple. First of all, thank the organizers to give for the invitation and also giving me the talk. So my presentation is on cervical lamino-foraminotomy. So we all know that the neck pain is the most common neurosurgical disorder in the neurosurgical practice and the most common cause of the disability. The approaches are two, both anterior and posterior. I'll be dealing with the posterior. Anterior more familiar to many of us, and we all of us practice. Lamino-foraminotomy, actually the disc surgery, first it was described in the lumbar disc, and then the cervical disc surgeries were described. And then also the anterior cervical discectomy is described 10 years later, following the description for the posterior cervical discectomy. So in that sense, the posterior cervical foraminotomy, laminotomy, and foraminotomy were described first treatment for the cervical discs. This was described by Fryklom, and Scovielli and Whitcomb actually promoted and did some more work on that. Coming to the few points about the neural foramen, we know that the neural foramen is basically by two pedicles, superiorly and inferiorly, and posteriorly you have facet joint, descending facet of the upper vertebra, and ascending facet of the lower vertebra. And anteriorly you have part of the vertebral body and oncovertebral joint, which everybody has highlighted recently. That is the uncinate process, which you get as a convex upward kind of bone when you do anterior cervical discectomy. So that joint also forms the anterior boundary of the neural foramen. So here is a simple anatomy. You have pedicle above, pedicle below, facet of the inferior descending facet of the above vertebra, and facet joint, and anteriorly oncovertebral joint, and this disc. So there are three areas. This I will skip. But most important is that in the foramina, 35 to 50% is nerves and the connective tissue, and the rest is by the radicular arteries and veins. And the veins are important because they form the messi for the operating from the posterior side. And most important point is that the posterior sensory nerve root is actually 3 times larger than the anterior root, and also has got a sensory nerve root ganglion. So this is the basic slide. We all know that lumbar disc can involve at any level 2 nerve roots. One is a traversing root and there is a exiting root, but that doesn't happen in case of cervical roots. Because of anatomy, only 1 root gets involved. And one more important thing is that you have a cervical disc. If you have a cervical disc at the C6, C7, it can involve only 7 root. And moreover, in the cervical region, because of the anatomy, the nerve root always goes above the pedicle of the corresponding vertebra. That doesn't happen in lumbar. Lumbar, the L5 root passes below the L5 pedicle, whereas in cervical, actually the root goes above the C7 pedicle, which we all know. Just this is important because when you have a clinically the C7 or C6 nerve roots which gets involved, you have to drill the corresponding neural foramina. That is at the level of C7 root. Because the C7 passes above the C7 pedicle, you have to drill the C6-7 foramen. So why lamino-foraminotomy? Lamino-foraminotomy is quick and immediate. It gives immediate relief and no spinal fusion required. And the most important thing is that most of these discs are common in the C5, C6 and C6-7 levels, and which are difficult to be approached anteriorly, C6-7 especially, and which can be managed by this simple and direct approach. Ideal candidate is a young patient with a soft lateral disc without significant cervical spondylosis, and contraindications are of course osteophytes and instability. If it is there, it's not a good procedure, and central herniations which cannot be dealt. This is a small video which I made, which I downloaded from the YouTube. So what exactly done is just drilling the Yeah, this is for the lateral discs, and of course, you cannot deal the central discs with this technique. So what you drill is the lamina, which is close to the facet joint of the above and below the vertebra, and also the part of the small drill of the small facet of above and below the vertebrae. This I will be showing in the video. So how safe? Good results are described, 70 to 96%. No revision surgeries are described and no CSF leaks are described in this. In several long series, this is one review article recently published, which shows that the posterior cervical lamino-foraminotomy is an effective treatment for the cervical radiculopathy. So several series have been published. The discectomies were described. The numbers ranging from 50 to 175, 200 are described with less complication rates and reasonably good results. So what all tools are required? Naturally, whatever in most of the institutes we have this C-arm and high-speed drills, especially diamond drill bits of 2 to 3 mm are required, and high-end microscope to visualize the anatomy clearly. This is the video. So you see, this is the 5-6 and 6-7 is the predominant level. As I told you, this was the big extruded disc. The prone position. Some people, it's better to make the head end elevated. C6-7 level, sometimes it is difficult to localize to the C-arm because you don't see all the vertebra in the C-arm. You have to drag your shoulders down to locate the vertebra. Sometimes we should be able to imagine anatomy from the, means the level has to be imagined and try to expose and then see. So this is this spinous process I had cut to expose this region. This is the superior side, this is the inferior side. I'm operating from the head side. So I'm drilling the inferior articular facet of the C6. The level was C6-7 on right side. So once you drill the descending part of the facet joint of the above vertebra, and then we have to drill the ascending portion of C7, which is an inferior vertebra here, and we cut the ligamentum flavum. The adequacy of the bone opening, initially you may not really be able to make out. Once you have the anatomy with you of the root or dural sac exposed, then you will know what exact amount of the bone to be drilled further. So here you are seeing the root there. This will be, and after visualization of the root, you can estimate the extent of the bone drilling which has to be done. This is called Tyler drilling after identifying the root. So this is the most crucial part when the dura is already exposed, and you should use a diamond drill, and you have to be very cautious about your drilling because you may injure the root there. And this is the beautiful way in which this root got exposed and the dural sac is seen. And once you identify the root, it is as simple as any other lumbar disc surgery. You incise the PLL, and I found this hook technique is the most useful technique in which you don't have to really expose it fully. So part of the disc which can come off, and once you take out the disc fully, as you see in this, the hooking technique in which you can take out the extruded disc. But of course, this should be only possible for the soft disc. Once you decompress thoroughly, you will have a beautiful bleeding from the venous veins around, the epidural veins, which indicates an indirect good decompression of the disc. And once you remove the big disc fragment, it is wise to go around and see whether you have left any small pieces which can also be removed. And this is the root, and this is the immediate relief of the root tension. And of course, definitely the patient also will have a significant clinical improvement on the same day of the surgery. I'm sure Dr. Goel will leave disc at least for us, but he is telling that even for the discs like this to fuse. Interesting, I was thinking in his entire talk that he will leave the discs at least for us. No, but the answer is no. So this is the patient post-op. This is another patient. Just I wanted to show this because the disc was at the same level, big disc like this. This was at the axilla of the root. Whether the disc extrusion is at the axilla or the shoulder, you cannot really make out from the MRI until unless you expose, drill the same story. You cut the, you widen the foramina. Actually, this should be the widening of the foramina, which should be done. Just bear with me, just 2 minutes, this will be done. So same steps, ligament of flavum excision. This is superior, this is inferior. An absolute hemostasis is required prior to you incise and try to expose the root, because until unless you have there will be small oozes from the surrounding the drilled area. Until unless you have a good control, you will not see a clear avascular field, which is a must to identify the root. Here, actually, the root is at the shoulder of the disc, and it is stretched out. I removed small bits of the bone from the ascending. So this is the disc material. The root, my suction is on the root actually. So you can incise multiple times to release the soft disc. Stretched out PLL, it should easily come off. Actually, you can see that when I'm removing when I'm incising itself, the disc is just dropping off from the, because of tenseness of the PLL, it is just coming out. Again, the same hook technique as I was describing, the hook can actually take out the soft disc in a better way. This is the relaxed root, as it is this is at the axilla of the root. The previous one was at the shoulder. And the residual disc fragment you can take out with good disc rongers. Of course, that was not available. This was not the instrument to be used there. And the residual disc, I came from this side, from the ipsilateral side. I was removing the residual disc, and using the hook technique, the disc has been removed. I usually keep a fat graft there, so just to prevent any CSF leak or of course, happy patient, post-op immediate as expected, and it is a safe and effective procedure provided your case selection is good. And of course, experience and expertise is required. All we require is just clear-cut anatomical knowledge of exact location where we have to drill, and the results will be definitely known during the intraoperative itself. You can feel. Thank you very much for your attention.
Okay, thank you. I think in the interest of time, we'll have discussion or questions later on. Next, I call upon Dr. Vedantam Rajashekhar to talk about long-term outcomes following central corpectomy for degenerative cervical myelopathy. Sir is a senior professor of neurosurgery and ex-head of Department of Neurosurgery at CMC Vellore.
Good afternoon. As the slides are coming up, thank you, Dr. Jha, for this invitation to share our experience with long-term outcomes. Yeah, so when we are dealing with a condition such as the degenerative cervical myelopathy, I think it's essential that we evaluate not just the short-term outcomes of our intervention, but the long-term outcomes. And this is something that is somewhat of a lacuna when you look at literature. So if you look at the follow-up duration, the follow-up duration here, you see it ranges anywhere between just 14 months. This is the range, not the average. Average is around 3 to 4 years, and 3 to 4 years is not adequate, believe me. You need follow-up durations in the region of 10 years, 15 years, to really say whether your intervention has been effective or not. In recent years, I concede that there have been some attempts at that. This paper from Emery et al. Had a follow-up duration of, mean follow-up duration of about 4.5 years. And there is this Chinese paper which had a mean follow-up duration of 8.5 years. The only problem was they had lost 50% of the patients to follow-up. So this was the impetus for us to do our study. And the technique that I have followed for close to 25 years, and I no longer do this, actually my colleagues do it, is this technique of uninstrumented corpectomy. And those of you who are probably sitting on this side of the auditorium may even wonder whether such a thing is possible. Believe me, it is possible. Yeah, you don't need any metal to keep this bone graft in place. And this is our experience with acute graft extrusion, where, as you can see, our graft extrusion rates were pretty high. In the first 100 cases, we had 6 graft extrusions, but as we went along, it sort of dwindled down to 1 in the next 100, and 1 in the next 100, and 0 in the last 300 to 400. So this is a large series of over 400 patients, and this is a fibula graft, and you need to make these mortises, and this is just a cartoon showing you the technique. You need to make these mortises to keep this in place, and absolutely no metal at all. So this is a 1 level, a 2 level, and a 3 level corpectomy. And this is these are some images to show you the type of decompression that you can achieve, completely free from both sides. And believe me, you need to see this kind of CSF in front and behind the cord to know that the cord is completely decompressed. And the fusion rate, and this is an axial MR postoperative, again showing you that the cord is floating in CSF, a fusion rates of close to 90%. So this was a retrospective study, but what we did was we had a prospective database. That means we gathered data prospectively, but the analysis was done retrospectively, and hence it does not qualify for a prospective study, to be called a prospective study. It's a retrospective study done over 17 years. I did all these cases of 482 patients, all of whom underwent central corpectomy, uninstrumented. So, but we included only patients with at least 1 year follow-up, and so the number drops down to 350 odd. And these are our definitions for categorizing the outcome. So improvement is more than 1 neuric grade change, improve. And cure is if at follow-up we had a neuric grade of 0 or 1, 0 or 1 being almost virtually asymptomatic. And in this group of 352 patients, we had 175 patients who had initially improved and had serial follow-up. So we wanted to look at the durability of improvement. So in other words, if a patient improves at year 1 after surgery, does the patient continue to maintain that improvement at year 10 of follow-up? And this was published a few years ago in the journal Spine. These basically are tables showing you the summary of the outcome. And one of the questions actually one of the reviewers asked was that is the outcome different with the differing durations of follow-up? So we looked at that. So if you looked at patients with less than 5 years of follow-up, more than 1 year to less than 5 years, 77% had improved by 1 neuric grade and 36% had achieved a cure. When it comes to between 5 and 10, the number comes down to 62% approximately and 32. And just as you go on to say, aha, the number keeps going down, you look at what happens at 10 years. Of course, the number of patients also has come down, but just to give you an indication that even at 10 years, more than 75% of patients had improved by 1 grade, and actually the number of patients who had achieved the cure was close to 50%. I don't claim that you will get that kind of numbers with long-term follow-up, but it's in the order of about 30 to 35% of your patients can achieve a cure, which is not very common in as a degenerative condition. And overall, the neuric grade changed from a preoperative neuric grade of 3 odd to close to 2, which is statistically significant. So what were the prognostic factors? The prognostic factors for just 1 grade improvement was age, negative prognostic factors, in other words, that is, older patients were less likely to improve, not that they don't, but more importantly, symptom duration was a strong predictor of outcome. So if you have a patient who has had symptoms of myelopathy for more than 1 year, then the prognosis is a little guarded. Again, not that they won't improve at all, but less likely to improve than those with a shorter duration of symptoms. When it comes to cure, then again, both these prognostic factors are significant. That is age, younger age, and symptom duration of less than 1 year. But if you have a patient in neurics grade 4 and 5, that's the most disabled, they are less likely to achieve a cure. And that's understandable. That's quite intuitive. Now we come to this durability of improvement, which I talked about at the beginning of my talk. So we had 175 patients. They were followed up for a mean follow-up of 6 years, ranging from 2 to 19 years. And the improvement rate in these patients, 175, this subgroup of patients at 5 years was 90%, and at 10 years it had come down to 76.3. And when we looked at these predictors of the durability, again, the duration of symptoms was the major predictor. If you had patients who had longer duration of symptoms, then as you can see, with time, their improvement starts coming down. The preoperative neuric grade, on the other hand, it's counterintuitive. Those who are in the worst grades, actually, once they have improvement, they maintain their improvement. Whereas those who are in neuric grade 0 to 3 tend to worsen. And the only way I can explain this is that those who had worse grades, there is sort of very little to lose further. But these patients in the better grades can go down. But this was not statistically significant. So in other words, again, the duration of symptoms. We also studied what happens to these patients at the adjacent segment, what is known as the clinical adjacent level pathology, adjacent segment CASP as it's known. The other adjacent segment pathology is radiological, RASP, but this is clinical. So we looked at 353 patients, mean follow-up of 4 years. Our CASP rate was 4%. And when did this occur? At a mean of close to 100 months. That's over nearly 8 years. So in other words, unless you follow them up for that duration, you won't know what's happening at the adjacent segment. Then these are 2 examples where, as you can see, this is the initial MRI, this is after the corpectomy, and the CASP has occurred at the inferior level. It was not there here, as you can see in the pre-op MRI. And in this patient, it's at the other end. It's at the superior level, which, as you can see here, was not there. And this is the corpectomy level, and this is the superior level CASP. And the only predictor we found that was significant was, besides the preoperative, it was the preoperative neuric grade, and that is 1 grade increase in preoperative neuric grade conferred a 2-time or more risk of developing clinical adjacent segment pathology. We also looked at the poor grade patients, grades 4 and 5. In a previous study, we had 72 patients, again because in literature, these patients have not been looked at because the numbers are small in most Western series. We followed them up for about 3 years. I concede that's not really adequate, but we do have data from our other study that I talked about. But in these patients, interestingly, a quarter of them approximately can achieve a cure. 1/3 have more than 2 neuric grade change of 2 or more, and 76% improve by 1 grade. In other words, a patient who's bed-bound, neuric grade 5, can hope to become a neuric grade 4. In fact, every neuric grade 5 patient improved to at least neuric grade 4. So these patients should be given a chance. You need to operate on them, and this is an example of one such patient following a 2-level corpectomy. Again, the prognostic factor is the duration of symptoms of 1 year. That seems to be a very robust, and it's been borne out by other studies too, this 12-month cutoff. The last 2 or 3 slides I just want to address to the younger people in the audience. I'm sure you have already seen how to assess the sagittal balance or the sagittal alignment, lordosis, straight, and kyphosis, because this plays a very crucial role in deciding how you're going to do your decompression. And lordosis and straight, you can go both ways. Kyphosis, of course, only anterior. Age, I think if you're an elderly patient, I would probably try to go from behind if possible. Comorbidities, again, may be posterior, but this is an important player in where you go, whether you go anterior. I have a bias towards anterior surgery, so I will go and have a training in that. So I would prefer to do anterior. Those of us who are not trained in anterior may prefer or choose the posterior. Again, the resources, you don't need too much resources for a posterior approach. And so this is my philosophy of addressing these patients with degenerative cervical myelopathy. If there is a compression behind more than one or more bodies, up to 3 bodies or 4 disc spaces, I would opt for a central corpectomy, except when the compression is behind C2. I wouldn't go and do a corpectomy of C2, of course. Elderly patient with osteoporotic bone, because fusion won't occur. And if there is no anterior compression at all, which is extremely rare in cervical spondylotic myelopathy or degenerative spondylitis. If the compression is behind 4 bodies or 5 disc spaces, if it is lordosis or straight, then a laminectomy. If kyphosis is present, then I would do a 3-level central corpectomy with probably a discectomy at the adjacent level. But I don't look at the size of the canal. Is it a narrow canal or not, to decide, or if there is posterior compression, to decide on which way I go. And with this philosophy, over a period of 14-15 years, in 643 patients, we tended, as I told you, I have a bias towards central corpectomy. 80% of our patients underwent anterior surgery, whereas only 20% underwent posterior surgery. So I just want to conclude by saying that you need long-term studies. Do not be influenced by 1-year follow-ups, 2-year follow-ups to decide what type of surgery you want to do and whether that surgery is effective or not. And not only for degenerative condition, for benign tumors, for example, colloid cysts, vestibular schwannomas, meningiomas, you need long-term, pituitary adenomas, long-term studies. That's my message to the younger people in the audience. Thank you very much for your attention.
Thank you, sir.
We'll take the questions later.
It's an excellent talk always, but how do you calculate this 1 year? You stressed very much on 1 year duration of symptom. It's a spondylotic illness. Usually everybody will have more than 1 year symptom. It's not acute disc prolapse or anything. And also, all these people are more than 50 years of age. How do you calculate symptom duration?
So I should have clarified, it's the duration of myelopathic symptoms. So if a patient has got some, tingling in the upper limbs, that's not going to be counted towards their symptoms. It's myelopathy that I'm talking about, difficulty in gait, walking. There's nothing else you can go by. Yeah, but tell me how, unless you follow them up from birth. This is what is used routinely by even the AO study. They have done the same. There's nothing you can do about it. The multicentric, an international study, Dr. Kale is here. He will tell you that there's nothing else you can do. You just have to believe the patient. The patient says, I've had problems in walking for this long. You just take it, that time interval. You can't go in by anything. Not necessarily. Not necessarily. No, I don't agree with that.
Another interesting point is the long-term follow-up. I just wonder, how do you get such a long follow-up in these patients?
Yeah, so like I said, these databases were maintained prospectively. That means when the patient was operated, we entered their name, address, telephone numbers into a database. And in 92, of course, there were no phone numbers, but we wrote postcards to them and told them that we would want follow-up. Even with the best efforts, you saw that it's only about 80%. But yeah, that's the only way. You can't do it just retrospectively. One fine day, decide that I want to follow up all my patients for the last 20 years. You won't get this kind of follow-up. These were prospectively entered into a database. Yeah, and you need to have commitment. And, you have to persist.
Fantastic, Dr. Rajashekhar. It was a beautiful presentation. What I want to impress on, I'm sorry, you're saying? What you showed, your graft, the fibular graft, I'm sure the pharaohs in Egypt must be very happy. Because do you know that the pyramids, when the pyramids were built, there was no cement, there was no concrete, nothing. It was keystoning, like he showed, where they lock the bone into adjacent bones. I think that is a skill which every neurosurgeon should master, the technique of keystoning. See, when till 90s, implants were not available in India. Even PLIF was done only with bone grafts without any pedicle screws, and the success rates were 91%. When implants and pedicle screws came in, the success rates became 98%, but the complication of the implant set in, cost of the implant set in. But this technique, which he has been showing over the years of keystoning, is not easy to master. It requires a certain amount of carpentry, but every neurosurgeon should have it in his quiver of arrows when he's dealing with spinal surgery, is because when implants get infected and you have to remove your implants, you must have this skill with you in your quiver to treat the patient. When you retrieve the implant and you still want to get a fusion, you must know the technique of how to do keystoning. I must really congratulate. And I've been seeing his presentation over many years, and these slides of how he puts the graft and locks it into the vertebra above and below, it is fantastic.
Yeah, so I must acknowledge my mentor, Dr. Dick Saunders, Richard Saunders, who introduced corpectomy to the neurosurgical group. The orthopedicians had been doing it for about a decade before us, but the neurosurgical group, Dr. Dick Saunders at Dartmouth, retired professor of neurosurgery, was the one from whom I learned it. So I must acknowledge his.
I congratulate you on the long-term follow-up.
Thank you.
So why did you exclude the patients who had not improved by 1 year? Wouldn't skew the study?
No. Sorry, you misunderstood me. Those were also included.
Okay.
In the 352. The cohort of 175 are the ones with serial follow-ups.
Okay.
You're talking about only for stability, for whether the improvement is durable or not, is only those who improved, I can say they are durable. If they hadn't improved itself, there is no durability of improvement. So the 352, everybody was whoever. You're talking about the ones with no follow-up, I can't do anything about.
No,
I don't.
not follow-up. Okay, so you're telling in the 353, all are included in the long-term follow-up,
Correct.
Improvement and non-improved.
Yeah, but they didn't have serial follow-ups.
Okay,
They may have had just one follow-up at 10 years. They may have had one follow-up. Serial follow-ups is 175 patients.
So the 60 to 70% improvement at 5th year and 8th, this is both?
Correct.
Okay, thank you.
Yeah.
Thank you very much, sir.
Just one question, sir. What about patients who are osteoporotic? Do you analyze the bone preoperatively, and does it make any difference in your approach to this patient?
Absolutely. As I mentioned, if I figure out that they have severely osteoporotic bone, I wouldn't do an anterior surgery at all. No question. Because the fusion will not, it will not take. Thank you. I think we need to move on. Thanks.
We move on to the next speaker, Professor S.S. Kale, Professor and Head of the Department Neurosurgery at AIIMS, New Delhi. Professor Kale will speak on management of cervical kyphosis.
Good afternoon, everybody. It's difficult to keep awake after a sumptuous lunch. But then you have Dr. Goel to wake you up. And I hope everybody is wide awake now. Thank you very much, Dr. Deepak Jha and the organizers for this very nicely organized, 1 second. No, no. Go. So very nice organization for this Rajasthan Neurosciences update. Thank you very much for this opportunity. Some of the cases which I'm going to show, I wish I could have sent them to Dr. Goel. Just do a simple operation from behind and they would all become straight as a ramrod. But I don't know, somehow it didn't strike me. So let us see why I did not send them to Dr. Goel. Thank you. Okay, so they're all syndromic people. They're all young people. They're born with some genetic problem nature has given them. And before they become 15, 16, they develop these problems. And they all multiple problems because some of these syndromes involve the heart, the other organs of the body, the joints, all kinds of problems. So I wish we could just do from the back and just wait till they improve. But then somebody had a heart surgery waiting, a mitral valve surgery waiting, because he had so severely myelopathic that he could not eat. So he had to be done first before the heart surgery, etc., etc. But let us see what happened. So we all know this. This has been discussed by many of the speakers before me. What exactly do you mean by kyphosis? This is what happens to the spine when it becomes kyphosed. Does this pointer work? Yeah. Yeah, it does work. So the first child was referred to me from the northern part of the country where she was first dealt with when she was, I think, 4 or 5 years old. They saw this kyphosis in her spine. They noticed there is some atlantodental interval is also increased. And they thought, well, let us just put a halo pelvic or a halo vest fixation. They did that. She developed osteomyelitis in the skull. So they had to remove the halo. Then they didn't know what to do. And so in the northern part of the country, if you don't know what to do, just refer to All India Institute of Medical Sciences. This is what happened. And she came, and this, I think, many years ago, 2 decades ago. I didn't know what to do. I was also, my hair were black and I didn't have a paunch. And I was very energetic. So I said, okay, I'm going to solve this problem. But I was wondering what to do. I mean, it was difficult to see the pedicles. The pedicles were so small in an 8-year-old. So I thought, how am I going to do a fixation? And how am I going to go anterior at C3 in a small child? So I did only a posterior fixation. Occiput, the C2 screw is, I think, in the pedicle. The others are in the lateral masses. We put a lot of bone graft, and you can see some titanium cables here. We pulled the C1, C2 together as well. And this was an X-ray taken when she was, I think, 11 or 12 years old. It's not very good looking, but she was holding. There was no myelopathy and the construct was stable. So we then did the rest of the problem. She had multiple problems. This was another problem. I wish that can be dealt with by just doing facetal small screws. It would be so nice if you could just put facet screws and just wait. And she would become miraculously all right. But I don't think facetal screws are going to do anything in this kind of deformities. Nothing at all. You need to do something else. And that's what we did. We put a magic rod. That time, the magic rods were the new thing because the child also has to grow. If you fuse the whole spine at 8 years of age, how is she going to grow? So we put this and we keep distracting, let the spine grow. And she has grown into a very pretty young lady. She was from Himachal. But unfortunately, her problems were multiple. She had some joint problems. She had hip replacement, knee replacement, all kinds of troubles. But however, her spine remained straight, and there was no myelopathy in the last 20 years after we dealt with it. Another 23-year-old, Marfan syndrome with this kind of a deformity. I don't know, will just facet screws work here? I don't really know. This was fixed. This was not moving at all. There was no mobility in the spine. So we said, okay, I'm going to try and fix the whole thing. We did this from the back. We did only posterior. And this is what we did. We said, let's wait and see, maybe this thing will work. He was all right for 2 or 3 weeks after surgery. We let him go home. And within 3 months, he was back. And what had happened? You do a long fixation anywhere, the adjacent segment is a suspect. And if you have taken the occiput, then the whole load is going to come on the junctional junction at the bottom of the construct. And that is what happened, started falling off here. And then we had no alternative but to extend the whole thing. And then I thought that, well, going only posterior and then going from occiput to T2 in every case of cervical kyphosis, I don't know, is that the treatment or should we think of anterior surgery? Anyway, so the strategy so far was only to do posterior. And then we had this young boy, 20-year-old with neurofibromatosis, and he had been waiting for many years. Many people had seen him, and nobody did facetal fixation for him, unfortunately. So he came to us, and then we thought, okay, this thing won't, facets are not the answer to this. We'll have to do much more than that. So we did all this. We did some decompression from the back, and we did fixation from the back, but again, only from the back. And just like we saw a junctional problem at the lower end of the construct, here the junctional problem happened after a few months in the upper end of the construct. He started to pull out the screws from the head. However, the rest of the spine and myelopathy was gone, so he was quite happy with it, and he did not let us touch his head again. So one side, the rod is out of the skull, but his spine is fine, and he is okay. There's no myelopathy. But still, the problem kept rankling in my head that only posterior, there's some problem. You have to do a very long construct. You have to go from the skull to the dorsal spine. And then we had this young lady, again with a spine like this. And the maximum extension possible was this, and the spine was still kyphotic. So this time we had new gadgets. We had MEPs in our operation theaters. So we were monitoring her cord, and we did exactly what we had been doing all this while. Go from the back, use the pedicle, use lateral masses, whatever you can, do a posterior fixation. And the moment we did that, her MEPs dropped significantly on one side, and the physiologist in the OT said, okay, you need to remove the rod. So we said, well, then we have no other way to deal with this except going anterior, because putting the rod back in without doing some decompression will cause a problem. And there were disc bulges everywhere. So then we put these cages, didn't do a corpectomy, we just put these cages and a buttress plate, basically to stop the movement anteriorly as well. And then she did all right. So I said, okay, so anterior is probably included in this whole thing. And then again, we had this problem. Young boy, he was I think 185 or 190 centimeters tall, long spidery fingers, all the typical features of Marfan syndrome which I had ever seen or read about. They all were there in this young man. All the signs you can think of. Everything was there. Arachnodactyly, wrist sign, thumb sign, pectus excavatum, high arched palate, crowded teeth, dolichocephaly, everything. You name it, he was the typical Marfan syndrome. Again, we did the same thing. So here we said, okay, we need to take out that knuckle of bone, that C3. The C2 and C4 were touching. So I wonder how facet manipulation is going to help that. So we said, well, I have to take out that C3 body, which is the root cause of the problem, causing hemiparesis in him. But we did that, and the MEPs dropped, so we removed the distractor between C2 and 4, waited for some time, gave steroids, didn't know what to do. This was the first time I had encountered the MEP. Was a new tool in our OT. But thankfully they recovered, and we carried on with the operation. And we did exactly what we had planned, that, okay, I'm going to do anterior, I'm going to remove that knuckle of bone from the back. Before that, we had gone posteriorly and loosened the facet joint so that we get more correction anteriorly. And still, we couldn't get a complete correction, and you know this by the angle of the top end of the cage. You see, if it is a good correction, the cage should have been angled the other way around, or maybe completely horizontal. But it just wouldn't move beyond this. And so we left it at that, and we put a buttress plate in front and then went from the back and completed the operation. This was the result of his after surgery. And now I think it's a 6 or 7 year follow-up. He's doing fine. He has added another 10 centimeters to his height. He's 200 centimeters tall now. But his myelopathy is gone. Both his hands and feet are fine. And his neck, whatever this construct is holding fine, the upper and the lower end of this construct. So now I said, okay, so we have this strategy of first going from the back, loosen all the facet joints, come from the front, do the correction. The main part of the correction is anterior. And if you want to correct that, then corpectomy is a simple alternative. You do corpectomy, you get enough space. And then go from the back again and correct it. So, and lo and behold, the moment you think that, okay, now you're getting there, you get another patient. Here again, I wonder if fusing the facets is going to help in this. I doubt it. Here the C2 and C5 were touching together, and the C3 and C4 both were buried inside. I don't know how to do this. I said, well, I'm going to do the same strategy which we have managed till before. And this one had florid Marfan syndrome, including valve problem, the cardiac problems as well. This was what his MRI looked like. So difficult to do everything from the back unless you have to decompress. There is no other way. Otherwise, I don't know how many years it will take, if at all it will. So we did the same thing, front and back, back, front and back. First go from the back, loosen up everything, put your hardware in, come from the front, do the correction, and then complete the surgery from the back. And then after this, he started walking with a little bit of support, and then he went on to have his mitral valve surgery. He's still in follow-up, he's doing fine, and his construct is holding well. And then suddenly we had this torrential pouring of neurofibromatosis, syndromic cervical kyphosis. Here is an example. They have multiple problems, including the dural ectasias and tumors here and there, sometimes in the brain as well. And you have to deal with all these challenges if you are going to correct the deformity in such patients. And they can be, all these problems can be there, all these problems. So you have to deal with all of them and then correct the spinal alignment. Another example, this is what we did for him. This, I must confess, this was not me alone. This is a whole team, and this was done by other surgeons in AIMS. Everybody had picked up this posterior, anterior, posterior technique, and that is what was done. And it was managed quite well. Another example, younger child, horrible kyphosis with some fused vertebra. And this is what was done. Again, go from the back, first get the hardware in, then come from the front, do a correction, put a cage with a bone graft, and do that. So the debate was whether you should begin anterior first or you should begin posterior first. You have to do both, but where should you do first? And what led me to believe that is if you loosen the joints from the back, if you take off the facets or drill some facets or maybe just take off the ligaments, the mobility is increased, and then you get the final correction, you get it from the anterior part only. There is no way out. You cannot, the forces cannot be generated so much to correct this much of kyphosis only from the back. And that is why you do anterior correction and then you complete the operation when you go from the back. And this is how we managed it, these cases, how we did. And it was gratifying to see that even this short series of 6 patients of neurofibromatosis with cervical kyphosis got published in Spinal Deformity, which is a publication of the Scoliosis Research Society. For many of you who don't deal with this kind of deformities may not have heard of this journal. It's a kind of a very niche kind of a journal, just dealing with spinal deformities. But it got published there, and I've got many queries after that publication about this technique. Anyway, another example, and the same thing, we did exactly the same thing. Try and do as little as possible anteriorly to maintain as much vertebral body as possible. However, this has worked well, and if you see the correction of the Cobb's angle, the pre-op and the post-op Cobb, quite significant correction and alleviation of the myelopathic symptoms. And the MJOA scores have also been significantly better after this surgery. So the take-home message was you assess the curve, whether it is rigid or flexible. The aim is to get the sagittal alignment. That's the key. And whichever way you achieve it, back, front, only front, but the main aim is to get the alignment properly. For us, for rigid curves, the posterior, anterior, posterior seems to be working well. We have had good results with this. There are some adjuncts in the theater now which are available. Navigation is one, but in deformity, to learn about navigation is an art. It takes time to understand navigation when the spine is horribly deformed. And second is the MEPs. So if you have these adjuncts, use them. Why not? It only helps the patient. Thank you very much for your attention. Any questions, I would be happy to answer.
Thank you, sir, for your enlightening talk. We are short of time.
Okay.
The whole thing is about facets.
You know what, Shashank, he wants me to... but you know what, Shashank, I'm not sure if you have read my paper on deformities in neurofibromatosis. Have you read?
No.
Why you have not read?
I
In
don't know
that
if
paper,
such cases were there.
you know what, in that paper, yeah. There's a recent paper in, I think in some journal. You know, you are saying we have to assess the flexibility of the joints, particularly in cases with syndromic issues. In syndromic issues, in patients like this, the joints are completely flexible. Means they are open. I am wondering why you have to go from back first and go front later, then come back to back. I have a feeling these joints are so supple and so mobile, particularly in cases with syndromic issues. If you are, a friend of anterior surgery, go from front and then maybe come from behind. On the other hand, open the joint. You had one problem, and that is what is your story changed. One patient who developed this issue during MEP drops, and then you change the whole philosophy. I don't think one patient should alter your mind in such a way that you change your whole philosophy. My feeling is you could continue your, what you were doing earlier, maneuver the joint, keep the patient under traction during surgery, open the joint, demolish the cartilage quite elaborately and come from behind and get a solid little construct. And you can avoid this anterior, posterior like this.
Sir, sometimes there is fusion of the vertebral bodies anteriorly. That's when there is more rigidity. If there are 2 or 3 vertebral bodies which are fused together, there is no way out.
I agree, but you know what, my concept, which is changing over the period of 40 years of my neurosurgery, that compression, we are worried about compression all the time, and that is what decompression is the issue for all spine surgeons of the world. See, the cord is like such an elastic rubber that all kinds of compressions can be very beautifully handled. But this micro motion due to instability is the thing which cords cannot handle. You reduce this micro motion, you stop this micro motion. You see, when there is a large arachnoid cyst, the cord is not even seen and the person has no symptoms. When there is syringomyelia, the whole cord is not seen, the person has very marginal symptoms. You have neurofibroma, the cord is not seen, the person comes with hardly some pain here and pain there. This deformation of the cord, this compression of the cord, this should not be the primary issue or primary focus of our treatment. This is what I have realized.
So maybe it is possible. I don't know. It is this posterior, anterior, posterior has worked very well. Now we've got a series of 20 or 30 patients, and it's working fine. So never fix something which is working well. So whatever is working well, I plan to continue with it. I'll fix it when it breaks down. Till such time, this thing will go on. Thank you.
Now I invite Dr. Subodh Raju, HOD and Director Neurosurgery at AIG Hospital, Hyderabad. Dr. Raju will speak on degenerative disease of subaxial cervical spine, rationale for surgical management.
Good evening. Thank you, Dr. Sinha, team of AIMS Neurosurgery for having me here. After all these talks, this talk may look like, may look slightly redundant, but it's an overview of things and what we have learned over a period of time and how we changed our philosophy. I mean, it's always a learning process, and we keep on changing and keep on learning on these things. So everyone has learned about spondylosis, what it is, and these things, the reason, starting from disc protrusion to osteophytic spurs, and then the buckling of the ligament, the lamina, the hypertrophy of the facets, subluxation, then the altered mobility of the spine, telescoping or the subsidence of the vertebral body. This whole thing comprises the spondylosis, what we are talking of. And when we talk of disc degeneration, there are various stages as we go in throughout it. And that leads to all the features. And the features can be a static compressive myelopathy or a dynamic compressive myelopathy. Important thing is evaluation of these patients. And we should not neglect it based on only the MRI. And it's an algorithm of what we look at. And Dr. Rajashekhar mentioned the grading of the gait, and this thing is one of the important when we look at myelopathy. And when we look at myelopathy, we should not miss the differential diagnosis of myelopathy, like especially in motor neuron disease. And these features which come in myelopathy progresses very slowly over a period of time. So patient most of the time neglects it actually. He may tell 1 year, but actually if you ask, it may be much more, because we have to ask him some small leading questions, so then we know exactly the duration of these myelopathy, what happens actually. And when we see these signs of myelopathy, there is an evaluation protocol which we follow. And if it is definitive, then we go ahead with an MRI. And if it is no compression, we go for medical management, and so on, we go with the surgical management also. Starting with the most simplest of the thing which we get in our day-to-day practice as neurosurgeons, young neurosurgeons, the anterior cervical discectomy was the most common thing which we get in our residency, and after that. Looks simple if it is done properly. So soft disc herniation has its own method of doing it. Like we heard speakers talking about posterior discectomy, so we have anterior discectomy also. The limitation is that, yes, it requires a certain amount of skill. We may have to compromise some amount of the facet. And if it's only one-sided extruded disc, it's easy to do it. Where more familiar